Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guests are Bianca Carter and Gail Moore from the Visiting Nurses Association. Bianca, you've been with the organization for quite a while.
Yes, I have.
Can you tell us your role within the organization and give us an overview of the organization?
Sure, I'd be glad to. I've been with the VNA for almost 18 years, and I'm the Director of Development and Public Education, which I know is a mouthful, but I generally take care of communicating to the community why we're here and what we can do for them, and I'm in charge of fundraising for the organization. We'll talk about that a little bit more later. The VNA has been in the community in Albany, Saratoga, and Rensselaer counties altogether for 126 years. Next year will be our 127th anniversary.
Congratulations.
Thank you. And we've taken many forms, but we are a certified nonprofit home health care provider in those 3 counties, and we provide close to 125,000 visits a year. At any given time, we have 800 to 1,000 patients on our caseload, and everybody is in different home settings and in different healthcare situations, so it's really quite a challenge, and our goal is wellness for our patients. That's our primary goal. We employ registered nurses, about 70 to 80 registered nurses, LPNs, and the difference is the registered nurses are 4-year degree for the most part, and LPNs are 2-year, but they all take on different roles. Physical therapists, occupational therapists, and home health aides. And of course we have clerical and administrative staff to support those people out in the field. And they're out in the field every day of the week helping patients. For the most part, they work on a regular 5-day-a-week, 8-hour day, but we are also available 24 hours a day, 7 days a week on call. We do weekend work and holiday work, so we're always available for our patients when they need us. And we provide, for the most part, acute care services. And Gail will go into that a little bit more later. We do have some chronic care programs and some acute care, chronic care in between care, but our role is to go into the patient's home when they're in a serious situation, help them manage that situation, educate them about taking care of themselves, and make them well.
So for instance, someone goes into the hospital and they're discharged from the hospital,
yes,
and the visiting nurses will visit them for a few days, teach them how to care for their wounds, and go from there.
Right. That's in a nutshell. That's it. Some of our patients can be on our caseload for significantly longer than that, depending on their needs and the acuity of their situation. But primarily, we do see patients coming out of hospitals post-surgery. We do a lot of work with hip replacements. We do a lot of work with post-stroke and heart attack, diabetics who are in acute care situations. And yes, our education is very important, taking care of their situation. For example, a diabetic managing their nutrition, monitoring their blood sugar, monitoring their medication. These are all things that we do for patients in the home. And we get most of our referrals from physicians. In fact, a physician must be involved in order for our patients to be admitted to our caseload. And a lot of our hospital referrals come straight from physician groups. We do have employees, our own employees in the major hospitals in the area. In Albany Medical Center, we're a preferred home care provider for Albany Medical Center. And in St. Peter's and Memorial, we have staff there that actually help the hospital staff and the patients transition to home care from the hospital. So there's no gap in their care, in their services when they really need us the most.
And most of the payments are just done, it's covered by Medicare
Yes,
or Medicaid?
correct.
Either.
The bulk of our reimbursement does come from Medicare and Medicaid. Many of our patients are elderly and are needy. I would say probably 85 to 90% of our reimbursement does come from these two sources. But we do also receive reimbursement from HMOs, from long-term care insurance providers in some cases, and we do have some private pay. I would say probably 2 to 5% is private pay. It's fairly unusual, but those might be through people who are in custodial care, whose finances are being managed by law firms, that sort of thing, that we will receive some private pay from it. But it is primarily Medicare and Medicaid.
And can you quickly explain what JCO accreditation is?
Sure, sure. We are a healthcare provider, so we are monitored by a number of different organizations, primarily the New York State Department of Health. They will come in and survey us. They regulate the areas that we can serve, and we have to follow all their rules and regulations like any other hospital or clinic. And there are other organizations that in the state we're audited by them, but JCO, which is the Joint Commission on Healthcare Organizations, accredits us every few years. That's a voluntary process and a very lengthy process.
And it's stressful.
It's very stressful.
It is.
Yes, it really is. It's the white glove treatment. JCO is a national organization that puts the stamp of approval on a healthcare organization so that a patient coming into our care can really be reassured that they are getting the highest level of care. We spend probably a year preparing for the JCO survey because their surveyors will come in and spend several weeks interviewing us, looking at our patient records, inspecting the actual facility, going out on home visits, and monitoring exactly how our staff administers our care. Is it up to their standards? There are dozens of checklists. It's binders of checklists that we have to meet their standards. And we have been doing this for approximately, I'm going to say 10 to 12 years. I think we might be on our 4th survey coming up. And we have consistently been in the 99% percentile of ratings. So we're very proud of that and happy to do that. And that's also the seal of approval that we need to interact with many insurance and many HMOs and insurance companies require that kind of accreditation. So it's a grueling process, but it helps us to look at ourselves. It's a self-audit too. It really makes a big difference. So I started to talk a little bit about some of our programs. I said a little bit about chronic care and acute care, and maybe some of your listeners would be interested in some of our special programs. Most of what we do is what we consider to be our general care is the hospital to home type of thing. We do have special programs too. We do have a long-term home health care program, and that is a chronic care program. It's for a very particular population of people. It's primarily a Medicaid program, but it helps people to stay out of nursing homes if they qualify for nursing home care, and we can care for them at less than 75% of what it would cost to have them in a nursing home.
Wow. That's amazing.
It's a very significant program. It's growing all the time, and we do have that program in all 3 counties, and it's a great program. It was mandated by the legislature probably over 25 years ago, and it saves the healthcare system an enormous amount of money. We can help people stay in their homes and provide them, and it's a totally separate team from our regular nursing sort of acute care in and out type of visits. So it's a different population, and we provide lots of different services to them.
So fundraising.
Yes.
How do you possibly come up with the money that you need? We know how expensive it is to provide health care nowadays.
Yes, it is hard. One of our big goals, another portion of our population, is our charity care population. We provide probably $250,000 a year in free care in the communities we serve to people who do not have health insurance. And as people know in the audience, there are probably 40 to 50 million people in this country who don't have health insurance, and that number continues to grow. The harder we fight, the bigger it gets. And many of these people are working poor. You know, they literally are working jobs that don't provide benefits. We use certain identifiers to see who those people are. We help them out. People who are in between insurance coverage, people who have used up their benefits in coverage and need our help. We provide that care to them. You know, we're required to do so by the legislature, but we do it happily. It's part of our mission as a community-based organization. And we raise funds through our foundation from individuals in the community. They can be happy, satisfied former patients or families of patients, people who just have known us over the years or know people that we've cared for. We get significant corporate support, primarily through our golf event, which we hold in June.
So the golf event is the big event of the year.
It's the big event of the year.
Okay.
It's our big corporate fundraising event, and next year is our 20th golf tournament. So, and we usually honor somebody in the medical community, somebody in the healthcare community that we've worked with. We get some grants from. We've just gotten a big grant for telehealth, which Gail will talk about later. 2 big grants from the health department. But most of our support does come from the community, and the foundation has been around for over 20 years, and we've been very, very happy and able to take care of the charity care and take care of some capital needs, equipment needs that we have to pay out of pocket, and build up endowment funds to help ensure our future. You know, we're happy to be able to support a lot of technology programs in the last year or two and some capital needs. We've just gone to an electronic patient record, which means that the nurses carry laptops in the homes now, and this is a fairly new program. It's the last month or two. The last few months we've really had it out in the field, and we were able to support that program. It's made a huge difference in the patients' lives too, because there's not so much paper and the accuracy level is just skyrocketed. So it's a challenge, but it's a great organization to represent, and we have so many different programs that, as I said, the long-term program, the people do support individual programs. We have maternal child health programs, we have nutritionists, a geriatric alcohol program. We take care, our long-term program also has a component for AIDS patients, which is a very important piece of our work. And we do a lot of social work and community mental health work in the community. So the monies that we raise supports not only just the VNA's general mission, but a lot of those special programs too.
Thank you.
Okay.
Gail, we move on to you.
It's my turn.
The Visiting Nurses Association has been in existence for quite a while. Do you want to talk about how things have changed over the years?
Well, I would, because oftentimes we do get telephone calls asking us about what nursing does, and the older population tends to think of us as we were in the past. As Bianca said, we've been here for 126 years, and initially we were thought of as the friendly visitors, the people who came in with the program. It was called, I think, what was it, Fruit
and Flower Mission.
Fruit and Flower.
Fruit and flowers.
Fruit and Flowers, yes. Where we did bring food and flowers in to people who were home and the homebound, as well as delivering babies and doing well baby checks, etc. And of course, a lot has gone on in the past 125 years. Initially, I think way back when I was in nursing school, almost 30 years ago, I thought of the visiting nurse as the person who went around and checked people's vital signs and made sure that they were okay. Now, as hospitals have evolved and healthcare has evolved, we certainly have at home. Patients are going home sicker, and our nurses are highly skilled. They will go into the homes and make physical assessments, take the patient's blood pressure, listen to their lungs, evaluate the medications. If you kind of look at the hospital as the place where the acute care occurs, the patient's emergent situation is cared for, we're the people who, once they get home, teach them about their medication and help them to acclimate their life to whatever lifestyle change occurs. The diabetic, as Bianca had mentioned, may go to the hospital and start to learn how to administer their insulin. We're the ones who go in and taper their doses with them. We work with them for their diet, for their lifestyle changes, and so that they can incorporate their new disease state process into their life. So it's really kind of exciting, a different look on things. The nurses themselves see the patients intermittently. Oftentimes people will call us and they'll ask us for a nurse to come and stay for the day. That's not what the visiting nurses are about. We're not a private duty agency, we're an intermittent nursing agency. As you said, if someone has surgery and they're discharged the next day or 2 days later, we're the people that come in initially and do the dressing, and then we teach people how to do their own dressing and how to care for themselves. So it's a whole different process. Myself, I oversee the wound care program, the IV program, and infection control. Certainly I'm very partial to my IV program. We see approximately 200, 250 people at home who actually self-administer their own medications. Wow. And that's kind of a scary idea to begin with, of course. What it involves is someone having a catheter, either short-term in their arm or long-term in their chest, and they'll receive medications like antibiotics. They might receive chemotherapy in conjunction with what's given in the hospital, in the outpatient department, or they could be home on liquid nutrition for people who don't absorb regular food. Those patients, obviously, just even the thought of being home on an infusion pump connected to tubing that's going to go into a vessel in your vein is a scary thought.
Scary thought.
It's an absolute scary thought. Our nurses are highly skilled to know how to put the catheters in, how to care for the catheters. They're skilled in learning how to teach people to manage this equipment and these therapies at home. The advantage to doing it at home is oftentimes if you have a major infection, you can be on an antibiotic for a month. You can stay in the hospital and be exposed to the hospital routine and the possible infections that go along, or it's actually much better to be at home learning how to do this themselves. Our success rate is over 99%. So we certainly have a proven track record. I've been at the Visiting Nurses doing home IV therapy for 14 years. This program has been in place prior to me coming. So people actually have been doing this at home for a long time. It's a scary thought, but once the individuals learn or their caregivers learn, things work very, very well. Obviously, we work in conjunction with physicians, and we work in conjunction with the hospital to troubleshoot any problems that we might encounter. The nurses are very proficient in administering the medications. They know the side effects, and as with any professional who does things over and over and over again, they have developed a great expertise. I've showed you this picture of our nurse administering medication to our patient via a pole-mounted pump. We also have ambulatory pumps like this one. Runs by batteries, and the medication is either in a cassette or it's in a bag. It goes through the pump, through the tubing. It will be connected to the patient, and the pump itself administers the medication. It could be a medication that will be administered every 4 hours, every 6 hours, every 8 hours. So the patient needs to learn how to respond to the pump if it alarms, but is not responsible for administering the medication. They're responsible for troubleshooting. The nurse would come in, change the cassette, change the dressing, take the patient's vital signs and make sure that the patient is responding well to the medication and the disease is being treated appropriately. So that's one of my programs. As I told you, we have approximately 200 patients on, and our complication rate is very, very low. We're very proud of that. And our patients, I always look at them as our heroes, because our patients are just like you. my mom, my dad, my sister, people who have never had the thought of going home and doing this therapy, but with education and the fact that, you know, it's what's important for them to get well, they do very well.
And I think there's also the psychological factor as well. When you're in the hospital and you're not used to your environment, and your stress level is going to be so much higher.
Absolutely.
And plus the fact that your activity level is going to be so much lower. When, at least when you're at home, I would think you'd be moving around a lot more. And
you
you'd
would
be a lot more
amazed.
comfortable.
You would be amazed, and you are comfortable, and you have but you do have the safeguard of knowing that we have our nurses on call 24 hours a day, 7 days a week. The medications come from pharmacies that specialize in delivering home IV therapy. They're not the regular pharmacy that your CVS pharmacies. These are people who this is all that they do. So as CVS is excellent at giving out oral drugs, the IV pharmacies like Anthem, Quorum, Apria, these are the people that we work closely with all the time that have the knowledge of the medications, how they're delivered in the home and how they're administered. So it certainly is an expertise that has really evolved over the years.
Do you just want to talk about the difference between the conditions, acute versus chronic?
Yes, because as I told you, certainly anyone who's going to be receiving IV therapy, anyone who has a surgery that was done in a short period of time, and we're teaching you how to do dressing changes, that is the type of acute care that our agency is certified to administer, as opposed to someone else who has a chronic disease that has stabilized, and I'm thinking of multiple sclerosis, some disease state process where the person would need help in the beginning to learn about the disease. They would need help learning what medications to take and evaluating the effects of the medications. Once that piece is over, the evaluation piece, and the person has stabilized on their medication and are up to their highest potential, then they would no longer be in the acute phase and they would not be seen by our agency. Their chronic needs would have to be taken care of elsewhere.
So basically, when somebody's status is like this and there's no improvement as time goes by, that means your services are not needed.
Correct.
Right?
Correct.
Okay.
Correct.
Do you want to talk about telehealth?
The telehealth program, that's a new program for our agency, and we've been doing it now for a little bit over a year. We were lucky enough to have grant-funded funding for the program. This and our 2 current grants are through New York State, so that's been great. But the basis of the program is to teach patients to learn to monitor themselves and to change their lifestyles. And by that, as I told you, our nurses go in routinely, and we will assess their vital signs and we will assess their medications and ensure that people are doing what they need to for their disease. But with the telehealth program, that's to be done in conjunction. Once a day, the patients may go on the telehealth unit, which is in their home, connected to their phone line, and they may take their own blood pressures, their own pulse. There's a scale, which I chose not to bring, where they can have their weights monitored. They can also put a machine on their finger to have their oxygenation checked, and they can check their blood sugars if they're diabetic. Have that information be transmitted from the machine to a central portion of our nurses in our agency, where a nurse will monitor on a daily basis any changes in their vital signs and those parameters. The patients also will have questions that they ask, and the questions will be about their diet, their activities. It might be about their disease, their understanding. If the questions are answered in a way that we think that they don't understand their disease process, then there are cues, kind of an interactive learning where they'll be given information over the machine actually, but also the nurse is monitoring those questions. So then we already know when the next nursing visit is going to occur that the nurse who's coming in might need to do a little more teaching about diet or exercise or medication or compliance. It gives us another avenue, another window to look in to see the patients. If there are a problem with the vital signs or if there are a problem with the weight gain, the nurse in the agency will call the patient, discuss the problem with her. She may call the primary nurse and ask her to go out and see the patient, or she may not. She may just give this information to the nurse for the next visit.
And it's amazing how much a gain in weight can signal
Absolutely.
sickness.
Absolutely. This program, last year we were focusing on the patients who have congestive heart failure.
Yeah.
And just as you said, with patients with congestive heart failure, that's one of the first things that you're looking for. Change in the blood pressure, decreased breathing, or a weight gain. We can monitor those on a daily basis, report to the physician, and the physician's able to then order medications for interventions for them. Now, I can tell you that initially our concept was that we were going to use these units with the more healthy patients. But what we found was we could actually use them very successfully for our patients that have chronic congestive heart failure and help to keep them from going into the hospital. We teach them to recognize signs and symptoms. We teach them to call the physicians immediately, and they're able to get interventions much more quickly. So that's probably one of the best things that has happened over the past year. We hope, as time goes on, that we are going to use those, that we are going to use these routinely with our patients. And we've moved towards not just our patients with CHF, our patients with heart disease, but we've moved towards putting these in with our patients with chronic lung disease and with our diabetic patients, and that's what we're going to focus on next year because we've done so well with it in the past.
And I've got to say, I'm really impressed with the way that whole setup looks in your office.
Thank you.
It's really a great service.
And you need to be impressed with the patients, how well they do with it. Initially, you know, they're always a little nervous. Our telehealth nurse, Kelly Muller, she's excellent. She goes in, she'll explain the process to them, she connects them to the phone. They're worried that it's even going to interfere with their phone line, and we can tell them that doesn't happen. Things work very smoothly with the unit, and then the patients are very proud of themselves once they learn to monitor and then make that step from monitoring and looking at the numbers to actually learning to self-care, and that's what our goal is for them. And I just wanted to also remind you that we talk about the nurses and the things that the nurses do, but we also have our home health aides. Some of our patients on our telehealth program cannot manage to put the blood pressure cuff on by themselves. They can't manage to get on the scale by themselves. But our home health aides are trained to help them do that. So they're an integral part of this program. Our physical therapists, you know, because exercise is so important for wellness, our physical therapists are out there teaching people how to exercise, monitoring them, actually working with the home health aides to make sure that they're doing the exercises. Our occupational therapists teach them how to do their activities of daily living. If there are chronic lung patients who are short of breath, they'll teach them how to do rest and exercise so that they can dress themselves, groom themselves. Our focus is always getting back to the well state, or to manage the best that you can in the situation that you've got.
Well, your programs are very impressive. One last question. How do you think your services have affected the cost of health care?
That's a great question. And it's an answer that we're very proud of. Home care has proven over time to reduce costs of hospitalization and rehospitalization. The telehealth program is a perfect example. IV, if we can keep people out of the hospital, the average cost of a day in a hospital in the Capital District is about $1,500. The cost of the stated cost of a nursing visit, depending on the reimbursement source, is $135. That's a
Big
huge difference. And home health aid costs are even less, and physical therapy and occupational and speech therapy are also, even if you combined all those disciplines together, it wouldn't come anywhere near to the cost of a day in the hospital. And the psychological comfort level of people being at home helps them to get better faster. So all of these programs are designed to keep costs down. Home care is extremely cost efficient. We don't have the same kind of capital overhead as a healthcare facility does, and there's a time and place for a hospital, a rehab clinic, nursing homes, assisted living. We work with all those organizations in conjunction. But when home care is indicated, it really brings your costs down dramatically. And you'll see in many, many programs in the state and in the nation, the drive towards more community-based, back to going full circle to fruit and flower in a sense, back to community-based home care. It's becoming more and more important as our population ages and changes.
Okay. For further information, do you
Yes.
just want to give the website contact information?
Sure. Our phone number, our general phone number is 518-489-2681. Our website is www.vnaalbany.org. And there's lots of information, and also look for big changes in our website over the next year. We're trying to make it much more consumer friendly over the next year.
Okay. Thank you so much for coming. You
Thank
guys
you.
do an amazing job in the
Thank you.
community, and cheers to you.
Thank you.
Thank you for watching. We'll see you next time on Focus on Health.